a 3-year-old child at a well visit. The vision is 20/60 in both eyes. Do you refer or do you not refer? 3. What should it be? 20/50. Yep, for a 3-year-old. So do you refer at 20/60? Yes. Yes. You have a diagnosis of bacterial conjunctivitis, and the parents say they are absolutely panicked and afraid of drops. What do you prescribe? What kind of ointment? Erythromycin ointment. Yep. What is your first line treatment recommendation for dacrostenosis? Duck massage. How do you do that? Do you go towards or down? Down. Yep. Which one of these are the fixed ones? Esotropia or exotropia, or esophoria or exophoria? Which one's fixed? Yep. What is your antibiotic treatment of choice for post-septal cellulitis? What is the other name for post-septal cellulitis? Orbital cellulitis. Where do you treat this patient if they have a child with orbital cellulitis? In the hospital. So what are you going to treat? IV. Ceftriaxone and vancomycin. Yep, MRSA coverage. What's your most common virus for pink eye? Adenovirus. Yep. A child is 4 years old and they have bilateral acute otitis media without otorrhea. Is this antibiotics, or do you watch and wait? You could do either. It's a trick question. You could do either at 4. Nobody committed. You guys there's not a lot of energy in the room today. We got nothing today? No? It's a Wednesday and we're not at lunch yet? Okay. Okay. So we started with heat. We got through that acute otitis media and the otitis media, the serous otitis media. We got all of those. Now we're going to the external part of the ear. So you guys have learned all of this stuff again. Focus on the pediatric part of this. So same as the adults, you have the exudate, you have the external auditory canal that is involved. Same with children. They will not love when you just mess with their ear a ton, but it shouldn't cause any pain. So for otitis externa, it's very painful when you are moving the ear around. Because remember, for children, how do you examine an ear? Back and down. It's a little bit different than the adults. If you have kids that have had prior tubes because they met that recommendation to go see ENT for tubes, and what was that recommendation again? When do you refer kids to say, ENT, this is a recurrent otitis media? 3 and 6 months or 4 in a year, yep. So those children that have now an open canal, an open tube between the two, are going to be at risk for otitis externa with your bugs that cause your otitis media, which makes sense because now you have a vector from that media to the outside. So those same exact bugs. The discharge can be kind of scant or it can be copious. I will say, just in general, you'll hear a lot of, swimmer's ear and that type of stuff. What I've seen more often, and I see it a lot in teenagers and young adults, and even all of us, is from headphones. So people have their recurrent use of headphones. Think about the last time you actually cleaned off your headphones. Not that often. Now think that you're a 15-year-old boy and what kind of stuff is accumulating in there. So think about that as part of your differential. When you're looking inside the canal, there is obvious debris, but the tympanic membrane itself should be intact. So if you're manipulating the ear, you're looking for that obvious exudate, and you're looking for an intact TM. If it's not intact TM, it's like a secondary otitis externa. Remember why they came in? So when kids are usually coming in, parents are bringing them in here. It is usually because they are in pain. So your first treatment is to make sure that you address the pain that the kid is having. Again, what is your dosing for ibuprofen? 10 what? 10 mg per kg. And then what is your dosing for Tylenol? 10 to 15. Yep. Your next thing that you can do for this, because it is external, you can use your external agents for antimicrobial. So it's really nice because you can use your floxacins. Your floxacins are not ototoxic and they are safe to use with tubes, which is why that is the recommendation for kids, because you can use it for kids who have PE tubes and kids who do not have PE tubes. It's really nice too because most of the time the inflammation is what is hurting the child, really more than the debris itself. It's the canal that is inflamed. So if you put a steroid for that inflammation component and you put it with a floxacin, you have a brilliant combination that works very, very well. The kids tolerate that beautifully. So if you're combining, it's usually ciprofloxacin and a hydrocortisone or a dexamethasone. It's a beautiful drug, Ciprodex. Like, Ciprodex, makes sense. You can also try to remove this discharge. A lot of times it's really, really painful, so I bring them back for follow-up once they aren't as inflamed to be able to do an ear washout at that point. If you like studying this way, it's kind of a summary slide to get you to make sure that you know all of the goodness that we just talked about. You're preventing. So a couple of things. Number one, you have some teenagers, especially, and some young kids who just want to dig around in their ears, so you want to prevent over vigorous cleaning. Some people love those Q-tips. To a patient, I will say do not put anything smaller than your elbow into your external canal. It's really funny to watch kids try to put their elbow into their ear canal. The other thing, and you will see this on your pants, one of the ways that they will try to test this is you have a child who's on the swim team. They are in a summer swim program. They are staying at a hotel and they love the pool. Their family just got a hot tub. There was something that is how they are trying to do that to help you pick up on the fact that there are pseudomonas. And pseudomonas is one of those things that you need to put together with otitis externa in your mind. The other thing that I will tell families to do is use some sort of drying agent. So you could put after swimming, after showers, a small amount of rubbing alcohol or isopropyl alcohol in there, or use the cool setting of the hair dryer to dry the ear. If you use the hot setting, it's too hot. Try not to do that very well. Okay, so you got through the ear, which takes us into the nose for heat, which takes us, we only have a couple more things. So if we are looking at epistaxis, what do you think is the most common cause of epistaxis for kids? They're picking their nose, yeah. Yep, that is the most common things. So you typically see this with these young kids who walk around with their finger up their nose. A lot of times parents will say, I have no idea why they just keep getting these recurrent nosebleeds. You turn around and the kid's like halfway up their nose with their finger there. That's the first, number one cause is digital trauma. You can see this also with kids who have recurrent UTI or URIs. We will look at that in a little bit. But really what I see the next most common is foreign bodies. So kids, if you think about this, there are multiple holes in their face and they are going to put things in there. I have seen beads, I have seen Legos, I have seen peas, I have seen tortillas, I have seen all kinds of things shoved in nose, ears, mouth. The tortilla in the nose was the hardest to get out because it starts to disintegrate. So foreign bodies are one of those things. So if you have one nose, one side that has purulent drainage, or it is persistently foul smelling, it's usually how the pants will try to word this, that is typically a foreign body as opposed to epistaxis that has no preference for one side or the other, or a URI causing this. Certainly there's things to think about with bleeding disorders. A question stem or a history will likely give you something there. They'll give you there's gum bleeding, they have problems after the dentist, something else with that one, but things to think about. The other thing to think about is what's the climate? Are you down in South Florida and it's super humid and you're like, that doesn't make sense? Or are you up in the tippity top Pikes Peak of Denver, right? It's pretty dry there. So thinking about that climate, thinking about the surface area of the nose and the age of the child. Certainly, ABCs, I have seen nosebleeds be pretty profound where it looks like an exorcism happened in your exam room because there's just blood everywhere. That Kesselbach plexus has a lot of capillaries there. Certainly going to check for other sites of bleeding. And then literally doing a visual exam. What can I see up the nose? That is where I have found Barbie shoes, Legos, and beads, all kinds of interesting things. You just tilt them back and you can see exactly what they shoved up there. And they think, I have a hole in my face, I need to put something in there. Does anyone know what the special kiss is? You guys heard of the special kiss? What is it? Yep. So you occlude one nostril, so if you can see it, or if there's one side that you know something's going on, you occlude the other side, and then you blow into the mouth to try to get it to shoot out. Now let me be clear, is that you as the provider doing that? No, that is the parent. I say that because I've seen that happen. This is, again, the provider is not doing this. You are walking the parent through the special case. Occlude the nostril that you know is patent. Have the parent blow in the mouth and see if you can shoot it out. Did not work for the tortilla. Just did that. So things to do if you do have epistaxis in a child. It's going to be very similar to the adult world. So first, make sure they are sitting up, leaning forward. Everything that a grandma ever said of leaning back is not true. It will go down the throat and the child will then throw up on you. So now you will have blood everywhere and vomit from the child. If that persists and you can't see what's going on, a couple of sprays of Afrin up into the nose. You should have that as a clinic medication or something on site in your troop clinic. So if you have anyone with a nosebleed, this should work as well. You can also take gauze and pour the Afrin on it and then pack it up there so you have a little bit of occlusion to help with that as well. This is all for these anterior bleeds though. So if you think you have a posterior bleed or you can't identify where the bleed is, then that's certainly a time where you would need to have some specialists involved. If that persists and now ENT is getting involved, they will be the ones that will cauterize this bleed, or they will be the ones that will do true anterior or posterior packing. But we'll tell you a story. I had another provider, who's not a kid, in clinic who had seen that silver nitrate was an option for this. Silver nitrate is only an option if you can see the bleed. Otherwise, you go right through the mucosa and you end up making the bleed worse. In the posterior part of the nose is vasculature that connects to the carotid. So if you take silver nitrate to the posterior portion, you could erode right through and now you have a carotid bleed. Okay? So I will say it is in your textbook, it is there. Do not use silver nitrate unless you have trained with ENT and know exactly what you are doing. So it is there, but provider to provider, be very careful and maybe don't use that. Pack the gauze with Afrin first. Some of the prevention. This goes well. Try telling a family, don't let your child bite their nose. Right? It's very difficult. So avoiding trauma as much as you can, yes. If you try to tell a 3-year-old that, you won't get very far. So what are the things you're trying to do? You're trying to keep the air as moist as possible so you don't have drying of that friable mucosa. You can also take a little bit of petroleum jelly and put it on the outside and just on the very tip of the inside of the nares. That will be somewhat helpful. In the bath time, I always tell parents, use a nasal spray of nasal saline to help wash out the nose from all the dust, dirt, pollen that's going on in there. It feels a little less like you're waterboarding a child if you do it in a bath than if you do it outside of the bath. I still don't like it. We call it nose baths. I do it. And then if you're looking at, hey, they're having this recurrent friable over and over and over mucosa with breakdown, that's when you would say, hey, I need to do a swab to see if they're colonized with MRSA. So take a swab right at the bottom portion of their nares, send that to the lab. And if they are a carrier, then you can treat with mupirocin to get rid of that as a colonization. That's super helpful for families where you start seeing recurrent MRSA infections in different people. Go ahead and swab the whole family and get rid of that colonization for people. Just one of the things to think about. We're going to talk about the common cold because this is a big deal for these guys. So how many colds do you think a child gets a year? All of them. Yeah, what does that mean for in the first couple of years of a kid's life?
Always 6.
6 is the average, yep. How many, what in the bell curve, how many is considered normal? Up to 12. So if you got 12 colds a year, how long are they typically lasting for children? Yeah, 10 days, and with a post-viral cough lasting another week. So you're functionally, you can have a very normal child who is sick 3 weeks out of the month each month, and it's completely normal. And you have parents who are going crazy because they functionally have a child who in those first couple of years is sick all the time. It's the first time their immune system is seeing any of this. So you see multiple viral infections, typically between 3 and 6. Certainly with daycare, up to 12 is considered the normal amount. Most of them will go 7 to 10 days, so up to that kind of 2-week mark. Really that 10-day mark where you see where they are contagious, and then the hand fever, and they start to improve, takes you to that 10-day mark, which is really how we start getting the criteria for if you're worse after 10 days, that's when you start thinking that you have a secondary infection, such as a sinus infection. That's where that comes from. Any virus can get them, there's millions and millions of them. Again, most of them look slightly different, and you'll start learning those patterns. So again, which one, if you have eye symptoms, cough, fever, and eyes? Adenovirus, yep. I'm trying to think of the other ones that were on those other slides. We'll talk about those in home. You don't have allergy. It can look like any type of virus, so the same stuff that you see for adults. Their throat hurts, it's scratchy, they have a runny nose, they have a cough, they have a fever, they have a rash. Pick your flavor, any combination thereof. Some of the hard part is that there's not a whole lot to treat children with. So yes, you can do Tylenol or acetaminophen, and yes, you can do ibuprofen. Really can't use decongestants. Really risk-benefit ratio isn't there in these young kids, so under 6, you don't really use anything. The thing that parents will always say is, I would really want to use a cough suppressant. Please help me, give me a cough suppressant so that this child can sleep. What happens if you suppress a cough? Yeah, it ends up worse because now you have a stagnant pond where they aren't able to do that airway clearance, and now you have a perfect breeding ground for secondary bacterial infections. So I would caution you from ever, really, for anybody using a cough suppressant, instead using expectorants, using things to open it up so they cough more to get these secretions up and out. And for the love of God, if it is a virus, please do not give them antibiotics. You cannot treat a virus with an antibiotic. Except if you're using it for that. Which then is still for secondary. So that takes us to sinusitis, which is different for a kid because they don't come out with all of their sinuses fully formed. So if somebody ever says, hey, I think this 6-month-old has sinusitis, you should be very cautious about that because they don't even have the right anatomy yet to be having this sinusitis. So as a reminder through embryology and for your physiology, you come out with your maxillary and your ethmoid sinuses. As you age, your sphenoid sinuses and finally your frontal sinuses develop over time. So knowing the timing of that can be really helpful. Get something from an ER and urgent care, or you see somebody themselves, you're like, that doesn't make sense of what you would be having right now. The obstruction is the same child to adult, that mucociliary flow they do not have, and so that's where you get that secondary breeding ground and bacterial proliferation from that stagnant pond type mentality inside of that sinus. Same bugs. So if you haven't noticed this, you're seeing it over and over. These are the HENT bugs. So it's your strep, Moraxella, H flu, group A strep. Those are going to be the same ones over and over. So if you're like, how come we're using all of these same antibiotics for all of these? All of the different pathologies are going to have the same HENT bugs. So the sinusitis, most often when you're acute HENT bugs, they're the exact same. But it's harder to treat this because it's a hard area to penetrate. It's a nice open area that likes to just hang on to these bacteria, and especially if you have any types of Staph aureus. Staph aureus is a pretty sticky bacteria. We call it the grapes of staph, right? Because it looks kind of like the way that they cluster together and they hold on, so it's hard to penetrate that. One of the reasons that you see some resistance. Certainly anaerobes are hard to treat. So what you're thinking of in this child, that they've had something going on with a cough, a cold, something routine, regular, all of that's going on, and now you would expect them to get better after day 10 into day 14. Now they are worse. So now you have new headaches, new fevers. They never quite recovered. They are feeling worse, more fatigue. All of those things now are the secondary complications of what was a run-of-the-mill routine viral infection. One thing that people will come in and they will say that has no evidence that proves anything one way or the other, is they will say, the drainage from my nose was clear and now it's green. It must be a sinus infection. It doesn't really work like that. So the color of the drainage from the nose, or anything they can see, really doesn't have any more correlative factor of that. What you can see is if there is true blood coming from that, so not the friable mucosa on the outside, but if you see true bleeding, that can be one of the things that is worse. Don't do any imaging for kids. There's no standard labs. There's no standard radiology for kids. This is a clinical diagnosis that you are going to be making. If you get these, so if you get a CT or an MRI, you could be getting that for a completely different reason, and the radiologist comments and says, there's some sinusitis. And you look at this child who's completely healthy, and you're like, I don't know what to do with it. So it kind of works both ways. So really not a specific or sensitive imaging at all, so don't order that standard. Your treatment is going to be different than the adults. So while it is still a mox-clav, your timing is significantly longer. You are treating at least a full 10 days for kids. It is different from adults. So the timing of that is different. You must treat longer. So at least 10 up to 14 days depending on how sick the child is. So that's going to be your first line therapy. Why is this that high dose amoxiclav? Steve, what did you use low dose for? Group A strep? Is this for sure group A strep? No, so you can't use it. You have to use the high dose. So the high dose amoxiclav is what you're going to use. Things that make you more likely to have this resistance is if you have had antibiotic use in the last couple of months. So you're thinking just the timeline, how many kids are going to have these otitis media infections, how many kids are going to have stuff going on, and now suddenly you've got a recurrent or resistant bacteria. Under 2 is just more likely to see this as well. For these kiddos, if they are penicillin allergic, you still have to cover for staph, you still have to cover for those anaerobes, so it's a little bit different in your coverage. You can't step it up the exact same way. So first type is going to be your levofloxacin, and I really will say I haven't used that a whole lot. Kids don't tolerate that particularly well. The other one is your clindamycin, which if you remember from the other day where I said it tastes really, really terrible. It's the most disgusting of all the liquid antibiotics, so I'm pretty careful with that one too. So I will sometimes use those third generation cephalosporins like your Septinir with clindamycin. If you can get away, if you can at all, amoxiclav is going to be your best bet for a true sinusitis. And if you're really thinking about this, per the data, only about 50% of diagnosed sinusitis even is really sinusitis. So half of these kids will get better with time and as their body and their immune system responds. So that is one thing to talk with your parents and patients about, is most of these kids will get better. Do we want to put them through antibiotics, through severe diarrhea, through all the GI upset when it's a coin flip on if they're going to get better or not? So up to you as providers, up to you and the family to discuss. It's something to think about just based on the numbers. So what else could it be? Now you're not having nosebleeds necessarily. You don't have this sinusitis. What else could it be? So we're going to talk about allergic rhinitis. And this is one area that I will say words really matter. So you might hear families come in calling it hay fever. You're thinking to yourself, allergic rhinitis. I I would say one of the most common things that I see providers do incorrectly is the treatment of allergic rhinitis. Reason being, words matter. So if I say that somebody has seasonal allergic rhinitis, does that mean that it's all day, every day, forever? No, it means it's seasonally. This means fall, spring, summer, winter, a season of something. If it is all day, every day, all the time, what is that called? Perennial allergic rhinitis, right? So those type of words matter because your treatment is going to be a little bit different. This is going to be one of the hardest things to talk to families about, because a lot of families with children will have true perennial allergic rhinitis, and it is from something in the house. So yes, they could have cockroaches or dust mites. The most common thing that you see is that it is with a dog or a cat dander. So they are having this perennial allergic rhinitis, and the conversation becomes, are you ready to get rid of your pet? And if they say no, you say, okay, then your child will have perennial allergic rhinitis for as long as you have this animal. So that is just something to have that conversation with. What I often see is, child is allergic to the cat. They have seasonal allergic rhinitis. And you're like, no, they do not, right? So that is some of the words matter type mentality. What happens is then you as the PA or the doc refer them over to allergy for allergy testing, and the allergist is like, what are you even doing? Do you not know the word seasonal? So don't be those providers. If it's perennial from a dust, dirt, from a pet, it's all the time. Things that you'll see, just like the adults, sneezing, runny nose, some cough, some nasal congestion, a little bit different where you will see some kids, remember what it's called when they go like this? Yep, it's the allergic salute. So it looks like they do this, and you can see a crease on their little noses sometimes. Do you remember when it has the venous congestion of the eyes? It looks like they have two black eyes. Yep, allergic shiners. So you can see that in those kiddos. You see some of those things. And as a brief reminder, you have two parts of this. And this is again, because you're going to see it all the time, and this is where you just see some of the treatment mixed up because it's just such a common thing. There's an early phase and a late phase if you are having a true response to your IgE. So if you are truly allergic to something, it's your IgE response. And there's those two phases, your early response that has your mast cell degranulation, and your late response that has all of your other recruitment of your immune system. So all the cytokines, the leukotrienes, your basophils, your eosinophils, your T4 cells, all of the fun rest of the immune system that has your late phase that's going to have this continual inflammatory response, okay? Which is important when we talk about treatment, your early phase and your late phase. Just a reminder from that, because that gets into this. There's some cousins of allergic rhinitis. So when you see kiddos that have this, if you're specifically seasonal, you can see it with perennial things as well. The cousins are allergic rhinitis, atopic dermatitis or eczema, and asthma. So they are all three cousins of each other. So if you have one, look for the other cousins, because they will often go together. Things that you were looking for, we already talked about that. Cobblestoning was another one. So we talked about that in the eyes the other day. So you can see that with allergic conjunctivitis. You can see this with allergic rhinitis as well. That cobblestoning in that posterior nasopharynx or up in the nasal mucosa. Transverse nasal crease of the allergic salutes. We already talked about that in your allergic shiners. So it's going to be itchy, watery eyes too. What is your differential then? So your differential is going to be quite fast. So could this just be an infection? They have an upper respiratory infection? Absolutely. Could this be any kind of other irritant that is bothering them? Yep. Could this be the spicy food or they have a response to anything? The one I really do want you to know, the two are at the bottom. So your foreign body, so if you see that purulence from one nerve, so it's usually unilateral. So a test question likely will have to give you something about one nerve, one nostril, and a foul-smelling discharge that is different from this. The other one that you see in adolescence is that at some point They learned, or somebody told them to use Afrin for a couple of days when they didn't feel good, and then they have used Afrin ever since. So in residency, I did a rotation in allergy, and we saw it was an older gentleman, but he had come in and he'd been using Afrin every day, twice a day for 28 years because he couldn't get off of it. Right? So it was that profound that whenever he tried to not, the rebound amount of edema and congestion was super, super severe. So this rhinitis medicamentosa is a very real phenomenon that you typically see in adolescents who think that, oh, this Afrin really helps me breathe, and they end up getting stuck on it. So one of the things to ask if you have somebody that comes in, they're chronically congested, young airman that you pick it up at the VX, or a young soldier, or young Marine, or coastier, whatever we have here. Something to think about, because that is one of those kind of misdiagnoses, and by the time they get to allergy men, no one's ever asked them about Afrin. So when we think about your early and your late phase, this should help make sense why your first line is not the antihistamine. If you had an antihistamine, it only is covering that mast cell degranulation and that early phase response. So your first line treatment is going to be your intranasal corticosteroids, because that is going to help your late phase and all of those components of your immune system that were recruited and your early phase. That's why that is your first line. So it's one of the most common things that I see providers do incorrectly. So they'll say, oh, you have some seasonal allergic rhinitis all the time from your dog, perennial allergic rhinitis, let's give you some Zyrtec or some cetirizine. You're like, the diagnosis was wrong and your treatment was wrong. Right? So your first line is going to be your intranasal corticosteroids, early and late phase, for both allergic and non-allergic. Anytime there's that inflammatory response, you can use those intranasal corticosteroids. Going to reduce all of the inflammation because again, it's that upstream pathway. Let's talk about some of your side effects. So I bet you some in this room even are like, I hate Flonase, fluticasone, intranasal fluticasone. It gave me nosebleeds. And you're like, wait a second. So I can use it for nosebleeds, but it gave me nosebleeds. So I'm going to tell you provider to provider how to use it. Most people will take the pump and they will put it right up their nose, right into the hole, and they will give it a big spray and they will as hard as they can. Well, that did two things. One, it went down your throat, so now you are treating your throat, yes. Two, it got to the medial side, and on the medial side is where the plexus is, so your blood vessels, so now you've just thinned the area of your blood vessels. And three, it tastes disgusting, so you're less likely to ever want to use it again. Instead, you were supposed to use it cross-handed, so your right hand goes to your left nostril and vice versa, and it goes to the outside of your nasal turbinate. It's a teeny tiny little amount, and it should run down your nose, not to the back of your throat. So when people say it gives me nosebleeds, you know they're doing it wrong. They say I don't like the taste, you know they're doing it wrong. And then they say it didn't work. A lot of times they didn't use it consistently. So Flonase, fluticasone, Nasonex, budesonide, all of those are your go-to. So make sure that when you are prescribing things, that you know how to walk your patient through using them correct and why. Your second option then, now we've covered our late phase, so now we can go back and have an adjunct to our early phase, and that is when you start using your first or second generation antihistamines. I'm saying my go-to is cetirizine, has the least side effects that you see. Me personally, I think loratadine or Claritin is a garbage drug, it just doesn't work very well. And then out in the world, your special operators, your flyers, they will like fexofenadine or Allegra because it does not cross the blood-brain barrier, so you can use it on flying status, you can use it on any kind of arm status. So it's kind of a go-to for them. Second generation overall is less sedating, so that can be super helpful, unless you want to sedate. So if a child is still having breakthrough symptoms at night, that's when you would start to think, I'm going to use my adjunct to add a first generation antihistamine, diphenhydramine or Benadryl, for example. Knowing that there can be those kiddos that have that paradoxical effect where it makes them, wakes them up, so about 1 out of 10. You will see that in those kiddos. And it has that anticholinergic cross effect, so it kind of dries everything out. So they can wake up with dry mouth, dry nasal mucosa, those type of things. So as long as you know what you're doing, which generation you're using, you should be okay. Other treatment options. Now we've done intranasal steroids for any type of that allergic rhinitis. You've added an antihistamine on there. Other things you can do, there are nasal antihistamines. So azolastine or oletiapine are a couple that you could use. Probably remember that from pharmacology. They're not even as effective as your intranasal corticosteroids. Because again, they're antihistamines. They're only working on that early phase, not the late phase that is recruiting all of those. I've never seen anyone use a mast cell stabilizer. Proline is always out there and is always taught. Its dosing is 4 times a day. If I ask you parents out there to do something to your or with your kids 4 times a day, how likely is that going to happen? If I asked you to do something 4 times a day, how likely is that to happen? It's not. So the dosing really precludes us from using that. Your nasal anticholinergic. This one is one of my favorites. This is an under talked about medication. So it's ipratropium. So it basically helps dry up everything and dry up that runny nose, and it's actually indicated for the common cold. So if a family is like, give me something prescription-wise for the common cold, and they're over the age of 5, this is my go-to. And then last but not least, your leukotriene receptors. So this is part of that late phase, one of those recruited things, the leukotrienes. And so it is montelukast or singular. Not a great drug, but if you have that late phase recruitment that you see particularly when you have a component of allergic asthma, it's a great adjunct medication. So a lot of these kids will be on your nasal or even your inhaled steroids in addition to the antihistamines, in addition to your leukotriene receptors. Great adjunct. Little plug for immunotherapy. So one of the hard parts about sometimes being in the military is that we're constantly moving around. One of the things in allergy is if you're doing immunotherapy with the shots, they will have their proprietary formulas, and so every time you move around, you have to start the shots over. There's a program inside the military where they will do a standard set of 50 different allergens, and you can take it to every different base or post. It's a super cool kind of program. Something as an option for your active duty or those family members if you're seeing them who really just struggle and they've maxed out on everything else, and everywhere they go they're having these symptoms. So immunotherapy can be a beautiful thing to have. Avoiding G-congestions for children particularly, this can be okay, short-term use for adults. We don't use it in children. So we're not using pseudoephedrine, we're not using standard phenylephrine for some of the reasons that we talked about. Again, knowing the side effects and why you're doing that or not doing that. I think we're at the end of the heat stuff. So down into the throat. So if I talk about pharyngitis, is pharyngitis the same thing as strep throat? No. What's the most common cause of pharyngitis? A viral infection, absolutely. So if we're looking at that, pharyngitis, not the same thing. The most common cause, you guys already know that for, and it happens all the time. So any virus can cause a pharyngitis with it. Pick one, any of them, and then we usually, the one that we're looking for is your group A, beta hemolytic strep pyogenes. Is this the only bacteria that can cause pharyngitis? No, it's just the only one that we standardly look for and treat. And why? Of rheumatic heart disease. That is truly the only reason why. Other stuff can happen all the time. Your body most of the time will clear. But because of that risk, this is the one that we screen for. This is the one that's common. This is the one that we treat. The receptors on the back of a child's tonsils really don't pick up group A strep well. So that's why epidemiologically, under the age of 3, we functionally don't see group A strep. I think I had mentioned this before. One of the things that you'll see is people will say, well, my 2-year-old had it, and it was positive. Yes. Well, I had this, and they had a cough. Yes. There's always going to be those examples, absolutely. But under the age of 3, by the data, you really don't see kids that are getting strep pyogenes. Most of the time, these are high for them. The things on exam that you're looking for are all those things in the Centaur criteria. We're going to remind you of and go over again. If I said there's palatal petechiae, okay. What else did we see with palatal petechiae earlier this week? If I said Forsheimer spots, rubella, correct. So that was going to be one of the things. What if I said there's palatal petechiae, but there's also ulcerations on the palate? It's on their soles and their palms too. Hand, foot, mouth. What causes hand, foot, mouth? Coxsackie. Nice. So palatal petechiae is going to be one of those things you see. You're also going to see tonsillar enlargement and exudate. Can you still have strep pyogenes if you do not have tonsils? Yes, you absolutely can. And then this anterior cervical lymphadenopathy is pretty pronounced, so you can feel on yourself. You should be able to feel your lymph nodes. They just shouldn't be painful. And so with this, they are both enlarged in children and quite tender, very, very tender. So that's a hallmark of that. As a reminder of when you're talking about the size of tonsils and how large are they, so if you have a system where they are 4+, that means that they are touching or kissing tonsils. If you have a 0, that means either they don't have them or they are completely unable to be visualized. A 2 is when it's half of it, and then the 1 and 3 are between. So if you're really saying the tonsils are 1 + 2 + 3+, you know what you're talking about. And anything 2 and below is considered normal. So if you see 2+ tonsils, that is still normal. There's still more than 50% of that area that is open. So how are you determining then who's what? Is this more likely or not less likely? So the typical age is 5 to 15 for our world. So these ages 5 to 15 typically. They can have some nausea and vomiting specifically associated with it. A lot of times they're swallowing that purulent exudate, and that is what is making them so nauseated and having an upset stomach. The rest of those we already talked about, they are part of the Centaur criteria. If they said there's a scarlatiniform rash, what number disease is that? 2, second disease. Yep. And what is that rash going to look like? It's going to feel like sandpaper, but what does it look like? Kind of like a sunburn, sunburn-like erythematous with that rough over. If you had conjunctivitis, cough, coryza, and cough-like spots, what would you have? Measles, yes. The only reason I put this in here for you, because again, it is a reminder of your Centaur criteria, so please be familiar with your Centaur criteria. You will need to know it for this block. So an absence of a cough, as a reminder, let's go through it together. You have your anterior cervical lymphadenopathy, a true fever, so none of this low grade, it's a true fever over 38 degrees centigrade. Your exudate. And really the reason I want to point this out is that a lot of times we think your Centaur criteria is your diagnostic criteria. It is not your diagnostic criteria. If you have a score of 4 or more, so if you're looking far at the right side, what that really means, that means your risk is only more than 50% that it is strep. So really it's just a diagnostic tool to say who should I be swabbing or not, and 4 or greater just puts you at a little bit greater than a coin flip. So it is still a screening mechanism. It is not your diagnostic tool. Your diagnostic tool, then, is your rapid strep. And so that's a lot of times why we've completely gotten away from empirical treatment, because even at a 4+, you're looking at a coin flip. Your rapid strep testing is looking for the antigen itself. That is why then it sends it for culture as your follow-up. I predict in the next couple of years, while we are all starting to practice, we will be taking swabs that look at the PCR directly, and we will get away from these rapid streps with culture follow-ups. If we are looking at directly at the PCR, it will be one step and we will be done. That is not where we are, likely where we will be going in the future. Something to note, on your differential for a strep pharyngitis in a child is often mononucleosis or Epstein-Barr virus. For the longest time, I used to think if I'm going to go in and I'm going to get a mono spot, that the mono spot is another swab that I can get. So I can just do a quick swab for strep and a quick swab for mono. How does one get a mono spot? Blood. So now I have this poor child who doesn't feel great. I have now put something down their throat and I have to get a blood sample. So think about that. If part of your differential is mononucleosis, and you're going to get a mono spot, you will have to draw blood from it. So why wouldn't we just culture everybody, right? If you do it by the numbers and what we were just looking at, really you're not going to catch that more positive based on those numbers and that kind of coin flip based on your central criteria. So most of these again are going to be viral in nature. Okay, so now we have these kids. It's a group A strep, which means what can I treat them with? Low dose amoxicillin. Perfect. Yes, sir. Yeah, it will most of the time that will be the standard lab is they'll do a reflex culture is what they'll call it. So they'll, yes, yeah. So if negative, they will send still the smear for culture, and then the culture will come back in about 24 hours. Is usually what I would see. It would come back, and then a lot of times that will change. Yes, great question. Okay, low dose. So yep, because this is group A strep, even though it's a beta hemolytic, it's a group A beta hemolytic strep. This is your go-to for a low dose amoxicillin, so you do not have to use that high dose. You can use a penicillin or oral PenVK, so that is another option for you. And the one that I particularly love, if you have a child that you know tolerates your penicillins well, is your IM penicillin or your benzathine penicillin. You hear that in the hospital or in the clinic. The other name for it is bicillin, or the way I remember that, because it's a B, it is your butt penicillin. Okay? That's the shot that you get in your butt. So the bicillin or the benzathine penicillin. So those are another option. One of the things, if you don't know this child tolerates penicillins, and you give them butt penicillin, it's now in them for 10 days. So make sure that you know that you have a child who tolerates the penicillin and that you want this in them for 10 days. So you can't take it out. If they're penicillin allergic, cephalexin is your go-to. You can use, don't use clindamycin, but you could. Another option for you. And if they have a beta-lactam allergy, well now they can't use any of the penicillin or the cephalosporins. That's where you go to azithromycin. So please be aware of what you would do for a kid who's penicillin allergic versus beta-lactam allergic. And again, you already said it, we're treating this for the prevention of rheumatic fever. So that's really why this became such a highly process that we treat for that. As a reminder, your pants will love to get you on this one, that treating strep pyogenes does not prevent it from still being part of post-streptococcal glomerulonephritis. So PSGN will still have receptors that look close enough to each other that those antibodies will still go and attack. So it's going to help prevent rheumatic fever, but not PSGN. It's not going to do anything for that. And really, your antibiotic treatment for most people, and especially kids, is just shortening the course. It's just shortening how long they're going to be sick and how long they're contagious. It's really not going to change your outcomes dramatically. It's 24 hours. So what are your complications of this? So you treated it or you didn't treat it, and now they're coming back and they're feeling worse. What does a peritonsillar abscess look like? It can be a hot potato voice. What does it also look like if you're looking at the palate? You can have a deviated uvula, yeah, or you can see one palate that's dropping significantly lower than the other one. This can be a seeding for your otitis media that we talked about, or it can be another seeding for your sinusitis. So think about where else hint-wise that this bacterial infection could go. We already talked about rheumatic fever. You could have scarlet fever or scarletiniform rash. PSGN is another one, certainly. You've heard of toxic shock. And then one that I just want to put out there so that you've heard of it is something called PANDAS, so pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. This is a hot topic now in my world, and it's basically the acute onset of a psychiatric illness. It usually looks like an OCD, so an acute onset in a teenager of OCD in conjunction with a recent strep infection. So it's a hotly debated topic for pandas. If you heard about it, I wanted you to be able to know what I was talking about. So let's check a couple of things and then we'll take a break before we jump into the middle. 2-year-old male comes in with a sore throat, with cough, nasal congestion. Oh, I need to take that out. Low grade fever. Of 100.5 for the past 3 days. What's the Centaur score? Did they get a score for their age? Nope. Nope. Do they get a score for having a sore throat? Nope. Do you get one for having a cough?
No.
No. Do you get one for nasal congestion?
No.
No. Do you get one for a fever of 100.5? The Centaur score is 1. What's your most likely etiology? Viral. What are you going to do for this kid? Supportive care. Yep. Now the patient's 7, no cough or congestion, same temperature, and your tonsils are 3+ with Exudate. So now, do you get one for age? Yep. Do you get one for having no cough? Yep. Do you get one for the temperature? Yep. Do you get one for tonsils 3+ with Exudate? Yes. What is your most likely etiology? Technically, it's still viral. That's a trick question. Always viral. But what would you do? Rapid strep. Yep, and I would probably in Perfect, you guys got it. We got through heat, so let's take 10 minutes and then we're gonna push a little bit into like 12:10 so we still get a lunch and then we'll get you guys out. Okay? So 11:40.
Yeah.
5 times a minute. Right? That's never normal. But is it normal if they're breathing 40 times a minute? That might be normal if they're 9 months old. But if they're 4 and it's 40 times a minute, probably not normal. And there's some respiratory distress going on with that. Some of your sounds that particularly will be for pediatrics, as a reminder that stridor is an inspiratory sound versus wheezing that is an expiratory sound. So the air trapping is the way to think about that. So a wheeze, the air gets in and it can't get out. Talk about asthma, that's why. It's an air trapping disease. When you talk about bronchi and rales, I really defy you to go and find any practitioner anyway that can truly tell you the definition and the difference between bronchi and rales. Because really you're looking at where are the secretions that you're hearing inside the respiratory pathway, inside the airway structure. So is that in your intrathoracic airways or is that into your small airways? Nobody's going to be able to tell that with a stethoscope or even a bronchoscope. So really, bronchi and rales go together. You're hearing the movement of the secretions through the airway. So, as a reminder of that. Atelectasis, when the airways have kind of shut down and you see that closure of that, you see a consolidation, meaning that the airways themselves are filled with something, likely a purulent infectious process. You have a mass inside or outside, and any type of fluid with an effusion. So again, reminder of what we're going to be talking about. If you haven't heard croup or stridor, if you haven't heard these sounds before, you weren't in medical previously, and you're like, what does croup sound like? What does wheezing, or what, I'm sorry, not croup, what does stridor sound like? What does wheezing sound like? What does bronchi or rales sound like? These are a good video. The other sound that I think is helpful to know, that's really not in your textbook or anywhere, but it really helped me, was a sound that's called stridor. So you're like, stridor. What stridor is when you hear the upper airway noises, but they're not part of the lung sounds. So you would hear a child or an old man that's like, sounds like, you know, the breathing, like all of that kind of upper airway sounding noise, but you put your stethoscope on the chest and you're like, well, that's clear. You put your stethoscope in front of the nose, 70-year-old man, totally fine. Bad, good, bad. You're hearing stridor, so it's all in the upper airway. Okay? So that's what you do and how you differentiate it. You're hearing it in the lungs, you're hearing it up in the nose. You're in the anatomical considerations. This is really what I need you guys to be able to remember, is that children's airways are developed very differently and at a very different proportionate level. So your cricoid ring is the narrowest part of a child's airways, particularly those younger children, so under 3. So now I have a giant head and a different narrowing portion of my airway. So it's going to make airway management much more difficult for a child, a young child. Your older children and your adults, then your glottis goes pretty normal. And as you get older, so maybe a 4-year-old, it's kind of in the middle. 5, 6, 7, you're going up. So it takes a while to transition. But if you're thinking babies and those toddlers, your cricoid ring is that area. The other thing to think about for stridor is that it's that inspiratory sound from something obstructing that upper airway. So classically, we've all learned croup for stridor, but laryngomalacia is going to be the other thing that you see, where the larynx itself, because a baby, you've seen babies, they look kind of floppy. Their sphincters are floppy. Their heads are floppy. So why would the larynx not be floppy as well? So you see that kind of floppiness of the larynx that creates when it goes in, they try to inhale and you hear that stridor sound. So some of those differences in anatomical things with children. That means that respiratory distress looks a little different in children as well. So typically, where will you see kids on physical exam having problems breathing? So tripoding, what does tripoding actually mean? That is leaning forward. Why are they trying to do that? Opening up the airway. Yep, okay, yeah. Besides tripoding. Retractions, where? You see tons of retractions. Where do you see them?
Ribs.
So they're in the ribs, so intercostal retractions. Where else? Under the ribs, subcostal retractions. What about right here? Substernal retractions. Suprasternal retractions. You'll have tracheal tugging. You'll see that too. You'll see nasal flaring. You'll see that. And you'll see belly breathing. Especially for the little babies with those toad bellies. They're trying to recruit their abdominal muscles to help push air in and out. And so you're really checking all of those different places and all of those different positions to see what's going on with this child. The other thing, and that's just a list of that same thing. The other thing I wanted to point out, some of the other ones are obvious, apnea. Remember we talked about in block 1 grunting. Grunting is when they are literally increasing that intrathoracic pressure to try to keep the airways open. So if it sounds like they're truly a baby that's grunting or a toddler that's grunting, that's concerning. That's a sign of respiratory distress. For older kids, the other thing that I would want to point out, it's not on there, but kids really want to be successful with adults. And so you can start seeing them be able to only speak in very short sentences. So if you have a kid that, let's say 5 years old, 6 years old, whatever, and they're coming in with respiratory distress, and you say, can you tell me the alphabet? They will, and they'll try really, really hard, but they'll go A, B, C, D, E, F, G, H, I, and you only will get a couple of letters out at a time. So it's one way you can really look to see, are they in distress? Because they'll tell you, no, I'm fine, and then you can't really do their alphabet. Just something to try on. When we look at the upper respiratory tract, we're really looking at anything kind of larynx and up. So we already talked about the heat type things. Now we're moving down into the larynx. So we talked about croup, but the other way, and the way I've seen it on pins, is laryngotracheobronchitis. So that should be, where does my larynx and my trachea and the bronchi meet? There's some infection in that region. That's what we're looking for. So typically croup is caused from a virus. Most often, I need you to put it in your heads, parainfluenza, paraflu 1 and 2, but paraflu is usually fine to know. And you get that subglottic airway inflammation, which is the problem based on their anatomy, of right where that is. So if you say that the kids are peaking in 6 months to 3 years, typically the worst at 2 to 3, you're like, well shoot, that was right when they had that cricoid ring, and now it's subglottic, so this is bad. And you're like, yes, that's exactly why it happens, particularly in these 2 and 3 year olds, because they have the perfect anatomical setup for this. And a floppy larynx, and they're more likely to get these viruses that cause it, right? So croup is a perfect setup for a toddler. Usually worse at night. Think about what hormone drops at night. Your cortisol. What does cortisol do to your immune system during the day? Blocks it, right? So if your cortisol is high during the day, you feel better during the day. At night, your cortisol drops, your immune system comes out. That's not how I fight, don't worry. But now your immune system is going to town, and so kids, particularly with these robust immune systems, are worse at night with every infection, right? Adults too, but so if you're like, I felt pretty good during the day and at night, you're like, death is coming. Like, that's what. Your agitation and crying is going to make that worse because you're inhaling, so you're seeing that collapse of the airway. So for croup, that crying is worse, and you hear the stridor more. Again, just a reminder where that narrowing is, what happens when it is infected, and we have that severe edema. This is a clinical diagnosis. You don't need any labs, you don't need any radiology. If you did get a lab, it would be a PCR, and you would see which virus is causing it, most likely paraflu. Your imaging, if you got it again, would be an x-ray that is showing the steeple sign. However, much like your sinusitis, the steeple sign did not correlate clinically, so it's really not that much value added. You could see it on a child with a completely open airway, or you could see a child who's in front of you in respiratory distress and stridor and really not see it. But on your pants, if you see the steeple sign, that is associated with croup, tracheo or laryngotracheobronchitis, or paraflu. This is an example of what it looks like in the airway. So if you were trying to intubate that, you're like, that looks like a mess. That looks very difficult. What are your home recommendations? Well, we want to get as much of that edema under control as possible. So this is one where you want cool air, cool mist air. So when you open the freezer, a lot of times you get that cool air. For the love of Pete, do not put a child in the freezer. You would be surprised that you have to tell families this, but you have to tell them do not put your child in the freezer. Okay. Once you get into the ER, where a couple of things you're going to be doing. You need to control the inflammation right then, and you need to control it long term. So your right then medication, what do I do right now to get this under control, is your racemic epinephrine. So it is nebulized epinephrine that they're going to inhale. It helps with the inflammatory process and vasoconstriction to help open up that airway. It's a quick onset, but it's quick onset, it's a quick offset. So it's going to be very, very helpful right away, but it's not going to do anything long term. So your fix, your downstream for those later effects is going to be dexamethasone. Really weird dosing, 0.6 to 1 mg per kg per dose. So it's very strange, up to 12 milligrams. So like, that is a strange dosing. Dexamethasone comes in 4 milligram tablets, so it's probably why they were trying to make the math work, but just very strange dosing. Little thing about dexamethasone I just think is really kind of cool is that your IV dexamethasone has the same bioavailability as oral dexamethasone, it's just much more concentrated. So if you're in the ER and you see a nurse or somebody pulling up IV dexamethasone to give the child orally, and you're like, whoa, wait, it's totally fine, totally the same bioavailability. So you could either, in peds, what we'll usually do is either crush up the tablets, mix them, or we'll give IV orally. We don't often do liquid dexamethasone, it's high volume. You could also do prednisolone. It tastes disgusting and you have to use it for several days. So we've really gotten away from that and we do more dexamethasone. 1 dose. So it's really beautiful because you can do racemic epinephrine, you fix them very quickly, you give them 1 dose, you send them home, it's a great day for all. If it's severe, you've given at least 3 doses of racemic epi, or the parents are really scared and they're like, I'm not taking that child home yet, you didn't hear them breathe, it was really scary, you can always admit for hospitalization. So when would you really think about doing that? Number 1, if you're really small. So if you're under 6 months old and you're having airway issues, that's when I would at least admit overnight. If you came to the ED multiple times, so these families are ones that come and you can tell they are very scared, they are very nervous. They keep coming back. That's a sign, I am really scared of this child. I need help. Just admit them. It's totally fine. So repeat ER visits. If you think there's something else going on, there's something else in the lungs, And if they're having stridor while they're just sitting there at rest, that's a more ominous sign. So you hear it often when they're crying, but you don't hear it as much at rest. Your differential is always going to be epiglottitis. So we'll talk about epiglottitis here in a little bit. The sound that you're going to hear is a barking or seal-like cough. So if you've never heard that before, and you're going to go into a peds clinic and you're like, is there a dog in here? Is there a seal in here? That's what you're going to hear. It literally sounds like a barking cough with that. Laryngomalacia is when you have that floppy larynx. So if you see this but with no acute symptoms of infection, you're more likely that it's that floppy larynx versus an infective process. And then you can also have bacterial tracheitis as well. Very, very sick most of the time. It's an infection of the trachea itself, usually with staph, but those children are usually very, very sick. For all of these, I put a summary. If for studying purposes, if you know everything on this summary slide, you're probably 90% of the way there. Okay, so if you're getting, subglottic, the age range, a paraflu, stridor, barking cough, steeple sign, racemic epi and corticosteroids, you're probably good to go. So just for studying purposes, if you're trying to narrow it down, the summary slides will get you pretty far. Speaking of epiglottitis, this is a true medical emergency. So I don't know, has anyone been in medicine that has seen epiglottitis? You have. I have never seen it. So I'm going to pick your brain later because I've never seen it. Is it scary?
I didn't know what it was, but it's just I took an X-ray and that part was I've never seen this before.
Right, we've never seen it that much. What did the x-ray show?
It showed the Otitis was
Do you remember what the sign is that you see on x-ray? Thumb sign. Yep, thumb sign. And that's that big epiglottis that you're seeing. It's taking that airway. So typically, I don't even know why the textbook lists in that order, but when we think about it, we're thinking H flu type B or the Hib vaccine. Diphtheria can cause it as well, certainly group A strep as there. I've never seen a board question for epiglottitis that didn't give you the patient is unimmunized. Right? So that should key you into something if you're seeing that the patient is unimmunized. The child is going to look very, very sick, have some very high fevers, and the voice is going to sound that hot potato voice. Can anyone do a good hot potato voice? Somebody do a hot potato voice. Or make me do it. Oh. Right? It's like that hot sound, like where you have a hot food in your throat. The other thing that they'll usually do is they're trying to keep that airway open, so they'll do the tripoding or leaning forward, and they can't handle their own secretions, so often they're coming out. They're drooling and tripoding. So sick child, high fever, unimmunized, sitting forward drooling. On a test question or in life, epiglottitis can tell otherwise. Just like you said, gigantic epiglottis. So if you're looking at that, you're concerned that you have airway management issues. Normally you should be able to see the cords, see straight through. In that, you can't see it at all. So that's what you're worried about, airway management. Your lateral radiographs, again, you're going to see the thumb sign. But really nothing else on labs, so there's not going to be any standard labs. Again, a clinical diagnosis or with x-ray if you need it. And another example, gigantic epiglottis. If you're looking at this, so your treatment is going to be this, is get them somewhere where you can manage their airway with someone who is an expert in airway management and it is very well under control. So if that means it's in the trauma bay of the ER, great. If that means it's in the OR, awesome. If that's in the PICU, great. Anywhere where you can very quickly change to do a surgical airway if needed. Okay, so they will classically say perform it in the OR with anesthesia and surgery. It's because if it doesn't work, you'll need to convert to a surgical airway immediately. So anywhere where you could do that would be okay. You want to get the most experienced person with a pediatric airway. So often that's a pediatric anesthesiologist. but whoever in the hospital has the most experience with peds airways. And before then, don't touch the airway. Don't do anything. So if you're like, I'm just gonna get a quick IV in this kid, no, you're not, because they're gonna start screaming. I just need to give this kid a vitals check and nope, don't touch the kid. Keep them calm, keep the airway open as much as you can until the most experienced person takes over their airway. Once they have the airway under control, it's ceftriaxone, third generation cephalosporin, and some steroids. We'll say plus or minus steroids, that much edema, definitely go ahead and give them steroids. Again, same age, a little bit higher. Bacterial, etiology, muffled hot potato voice, where they're sitting, where they're drooling, get them intubated. So note that some of this. Foreign body aspiration. So we talked about it with the nose. Foreign body aspiration is something that the kiddos will do over here as well. So again, hole in the face. Kid wants to put something in the hole in the face. So it might be the nose. They might try to swallow it. The most ridiculous thing I ever saw a child swallow was a Christmas tree ornament, and it was perfectly in the trachea. You could see a little snowflake right in the middle. Right? They swallowed it perfectly, right down in there. So they will swallow anything. That's why baby-proof and child-proof homes. What we'll talk about when we talked about it for in block 1 was foods. So foods that are round and the same size as a child's airway, be very cautious of those. Grapes, hot dogs, cherry tomatoes. Doesn't mean they can't have those, just means cut them up or cut them somewhere they're not going to lodge in there. In the setting of a child that has an unwitnessed event, or really anywhere, if they were fine and now they're not, so sudden respiratory distress where they have sudden choking, sudden stridor, sudden respiratory distress like that, it is a foreign body infection otherwise. So particularly if it's unwitnessed. Your chest x-ray, you might get that lucky one where you can see the Christmas tree ornaments. More likely that you won't be able to see it and you will need a bronchoscopy with pulmonology to go in and take a look. To tell the story, the foreign body is not just kids. So the one that we sat with the most was a child who had gone, there was prom night, and it was him and his date, and they were trying to put the corsage and the boutonniere on, and she couldn't get the needle in, and so he was trying to help her, and he put the pins in his mouth, and she poked his finger, and he went like that, and swallowed it. So we had one in the airway and one in his GI tract. So he did not go to prom, and he spent prom with us instead. Right, so it can happen in the weirdest ways, with the weirdest ages. So foreign body aspiration, be prepared for that. Airway control again, so do not put your fingers in a child's mouth. And they will do anything, they will eat anything. I do not know why children love to eat coins. They're like, round metal objects? Absolutely, let's eat that. But that's a perfect thing that lodges in the airway. So remember, make sure, is it in the esophagus or is it in your airway? So aspiration versus inhalation. Aspirating versus, so this is a foreign body inhalation. This is another one in residency we saw. So a teenager, she was in class and she was always chewing on the tip of her pen, and she breathed in the tip of her pen. It was down there, needed a bronchoscopy to get it out. So typically you're thinking in a little bit younger kids, in the under 5, where they're just like eating coins for no reason. It can happen in anybody, it's very sudden, and then again, they will need bronchoscopy and that. And asthma's a big topic. You guys okay if we start asthma tomorrow morning at 8? Okay, we did it. You're gonna see right after Bishop told me at 8 o'clock in the morning,